including the interventions, the outcomes, and then a little bit about consent, IMP management, sample collection, follow-up, and site training. So just to remind people, this trial comes from a commission call from the HTA a long time ago, right at the beginning of 2018, been put on hold during the pandemic, but saying they really wanted to focus on sepsis trials and were willing to fund more than one, but we got together as a national consortium to tackle multiple questions about key elements that had come up in James Lind Alliance's priority questions for sepsis, and to ask questions about whether rapid PCR-based diagnostics combined with procalcitonin can improve antibiotic stewardship and outcomes for patients with sepsis in ICU. The second question is a conservative fluid therapy with active removal of accumulated fluid, i.e. what we call deresuscitation. Does that improve outcome in ICU patients with sepsis? And then in a sicker group of patients, a high-risk subset, does GM-CSF compared to placebo improve outcomes as an immune stimulant? We know many of these patients are immunosuppressed. Does it improve outcomes? And as well as clinical effectiveness, we need to know the cost effectiveness of these outcomes. So these are the questions that we want to answer in this large multi-center, pragmatic, multifactorial. So we're asking multiple questions at the same time. Most of it, the interventions are open label, so you'll know what you're giving in the larger trial. But in the overall big trial, there's a smaller embedded randomized double-blind placebo-controlled trial, which is the GM-CSF part. So the overall structure looks like this, which may be difficult for you to read in one go. So we've broken it down into two halves. You'll see the top half, which includes the fluids and the diagnostic elements. Patients in
you have something on your phone?
No.
Okay. So patients with sepsis in the ICU, so this is the large group, get randomized to the two different arms, the PCR or standard antibiotic management, conservative fluids or standard fluid management. And that's the large group. And then in this subset, we'll go through the details of this, the high-risk patients, smaller number get randomized to GM-CSF or placebo. So that's the overall structure. Let's just go into the details of who's eligible for the study in a little bit more detail. So it's quite simple, quite easy to identify the patients who are eligible for the diagnostic and the fluid elements, trial 1 and 2, as you want to call it, that top line. And they're essentially adult patients, so it's over 16, who are admitted to ICU due to suspected sepsis and expected to stay for at least 2 calendar days. So in other words, if they were admitted to, today, do you still think they'll be in the ICU on Friday? Doesn't have to be, things can always change, but the expectation is they're just that sick enough that they're expecting to stay 2 calendar days. We're saying that the suspected sepsis, again, it doesn't have to be definitively proved. That's part of what we're actually looking at. But it's essentially saying you're suspecting sepsis because you are treating them with antibiotics. And this is making them, at least is contributing, that infection is contributing to them being unwell. And we're also saying that they should have received their initial fluid resuscitation by the time they come into the trial. We're not mandating 30 mils per kilo or anything like that, but we're saying you should have replaced any fluid losses before they come in. They may need more, as you'll see, going forward, but you've completed that initial early resuscitation. So fairly simple who's eligible, just a few exclusions. We want to recruit people early into this part of the trial, so particularly around the diagnostic and the fluids. So it doesn't apply to the GM-CSF bit, but they need to be in their first 24 hours of their ICU admission, because if we're going to change these things, we need to do it early. So they need to be recruited within the first 24 hours. It's their first admission to ICU for sepsis, so they could have had an elective stay where they didn't get infected and so on. They could gone to the ward, but if they've fallen in a heap on the ward and come back now because of sepsis, they're eligible. But if it's a long stay patient who's been in and out of ICU with sepsis multiple times, they're ineligible. So hopefully, again, easy to identify. And we excluding patients who, because of their pre-existing chronic disease, are not expected to survive 90 days. In other words, we're trying to exclude those patients who are really sort of part of a palliative care process. They may have severe disease, and you might expect they might die in 90 days because they're now sick. But we just want to exclude patients who are dying for other reasons other than their sepsis. So that's it. If it's their pre-existing chronic disease, they have survival expected to be less than 3 months. And similarly, if it's acutely so unwell that you don't think they're going to survive the next 24 hours and are really on a palliative pathway, then they would be excluded. We think it's sensible, as we're talking about antibiotic stewardship, to exclude those patients who are neutropenic for other reasons, i.e. chemotherapy or malignancy. But if this is all just sepsis, they're eligible. But if they're, as I said, immunosuppressed for other reasons, with a neutropenia less than 0.5 neutrophils, they would be excluded. And similarly, if you think they need antibiotics for a very long course, so standard indications where you would give a 3-week or longer course of antibiotics. And similarly, if they need other fluid protocols because they've got DKA or DI or subarachnoid hemorrhage in the last 21 days. And then there is a weight restriction. So hopefully it doesn't exclude too many patients. This will be your general sepsis patients. Now to identify the sicker patients who are eligible for the GM-CSF, and we're trying to enrich in this group for two things: that they are sicker and more likely to be immunosuppressed and need benefit from GM-CSF. So the sicker patients are those who are intubated and ventilated, and you expect to continue that for 24 hours, i.e. just into the next day. Or if they're not ventilated, but you've two organ support, such as vasopressors and renal replacement therapy. We think these are that sicker group of patients with sepsis. And then with signs that they may be immunosuppressed to some degree, we're using the absolute lymphocyte count to less than 1.2 on 2 consecutive days, and so at least 12 hours apart. And it's this persistent lymphopenia is one way of identifying an immune suppressed population. As we've been talking to sites, many people have said there are other ways, such as monocyte HLA-DR counts. There's gene transcript stuff we're looking at that, again, are other ways, but these are not available in the NHS routinely. And so we're having to use a routine test that's available on your full blood count. And again, there's studies by people like Manu Shankar has shown this absolute lymphocyte count, if it's persistently low, is identifying an immune suppressed group who therefore you think may respond to GM-CSF. And just again, the exclusion criteria here, we allow the GM-CSF randomization to happen at a later point because you may not have those two lymphocyte counts below 1.2 on admission. So you can check that over time. So we allow up to 5 days for inclusion into this part of the study. And the exclusions here, if they're already receiving stimulating factors, if they already have a high white cell count, they shouldn't be included. If they're allergic to the product or any of its additives, so it's a yeast product, so if they're allergic to the yeast, they should be excluded. Pregnant patients are excluded from the GM-CSF part of the study. They can be in the fluid and the diagnostic, because that doesn't involve any concerns around pregnancy, but GM-CSF shouldn't be given to pregnant patients. And so therefore, if you've got a patient of childbearing potential, they have to have a pregnancy test before inclusion. And if there's an active hematological malignancy, which we've said is defined as treated within the last 5 years, they're excluded, or previous bone marrow or organ transplantation. And also, again, weight criteria here is larger patients because they're not going to get the right dose of the drug. So that's who should be included in the trial, the two elements of it, the initial randomization and the GM-CSF, which as I said can be later. We've got co-enrollment agreements for various studies. If you've got others going on, we can talk about it. You'll see some of them are antibiotic related studies, such as the DAP sepsis and the shorter trial. they obviously can't be co-randomized in both the antibiotic arms, but we could be in the GM-CSF part. Happy to go through that in a little bit more detail if people have got points. Okay, so if patient is randomized to the PCR diagnostic arm, what you need to do is send a rapid PCR test to the central lab via the safe boxes we'll send you. The test we're using is called SepTiC test. It's made by a company called Molzyme. It's commercially available. And it's a test that's in 2 stages. The first bit tells you whether there is a PCR product, bacterial DNA has been detected or not. And it will say the PCR is positive or negative, and therefore whether an organism has been identified that one exists. It doesn't tell us what it is, and you get that result first. If that PCR is positive, that PCR product goes for sequencing, and the organism is identified from that sequence, and you get the result the following day. As mentioned, we're combining this with procalcitonin, and the idea behind this is that we think these rapid diagnostics for PCR-based that identify the organism work best. Maybe we're combined with a test of the host response, the patient's response to infection. And we're using the procalcitonin here, which we want to measure on the day of inclusion. And it could be, if they've already had a test done before they came into the ICU, that's fine, if it was very recent, and then the following day. So how do we use these results? Well, if the PCR result comes back that next day, as I said, we send it off for sequencing. And we will give you that sequence, and then you change your antibiotics according to what the organism has been identified. And I'll go through that in a little bit more detail. If the PCR is negative, that means there's been no bacteria or fungus detected. Then we're saying, all right, now look at your procalcitonin, the admission one and the next day. And if both are negative, or it's dropped by more than 80% by the second time, that either means that we don't think you had an infection in the first place, or maybe it's already treated, then you should be stopping the antibiotics unless there is another objective reason for continuing them. So we've seen that in one case, we did have positive cultures from routine microbiology. And so the team said, well, we want to carry on treating the Klebsiella. The PCR didn't pick it up. Or if they've got things like white cells on their lumbar puncture, fecal soiling on laparotomy, a purpuric rash suggestive of meningitis, for instance, no one is suggesting stopping antibiotics in those cases. But if they just happen to have a little bit of a fever and the white cell count was raised, but both the PCR is negative and the procalcitonin is negative, then we should be stopping the antibiotics, with suggesting the rationale being that maybe the patient, as I said, never had an infection in the first place. I can see Jeremy's asked about procalcitonin in the standard of care. If that is your standard of care, yes, you can use the procalcitonin as part of standard of care. I'm not asking you to change your standard of care. You can use that, but you wouldn't have the PCR, and you're free to interpret the procalcitonin in the control group any way you like. We'll mention that in a moment in a bit more detail. What will happen if you get the PCR back? Sorry, this one first of all shows if it's negative here. You get the instruction, the report will come back to you, and you can see the negative result here. Just going through what I've already said to you, you'll get that reminder in the report. If it's positive on that day 1, it will say that potential pathogenic DNA has been detected. Carry on your antibiotics, and more information will follow the next day. The next day, hopefully, we get the sequence back, and it says what the organism is. And this test is very sensitive. It can pick up most bacteria, and it may pick up both pathogenic and non-pathogenic bacteria. So when I say that, what I mean is these are the list of bacteria that, when you detect them, are likely have a high chance that they're actually causing the infection that's causing the sepsis. So you'll recognize the bacteria we commonly detect in critically ill patients here, whether it be streps or staph, enterococcus, and the gram negatives, whether it be Pseudomonas, Klebsiella, E. coli, Enterobacters, and so on. If it's one of those bacteria on that list, you'll get the report back that says, is here XX, so Pseudomonas has been detected in the blood specimen. This is a recognized cause of sepsis. Make sure you talked with your microbiology service and optimize the antibiotics for that organism. If it's a organism that's not on that list, we will tell you that it's been detected, and maybe it's going to be important, but we say this may be associated with sepsis in some circumstances. And therefore use this information, discuss with your microbiologist, and you decide if you think you want to change the antibiotics. A bit like when you get a blood culture result that's grown staph epidermidis, for instance, or coagulase negative staph. Most of the time you probably wouldn't treat, but there would be times when you think in individual cases you may want to change your antibiotics appropriately. So that is how we expect this to work. And as I said, in the standard of care, you prescribe your antibiotics as you would normally. Again, it should be, best practices in consultation with microbiology teams, de-escalating short courses as clinically appropriate. And Jeremy's question about the PCT actually is commonly asked because a lot of sites are now using PCT more commonly. And absolutely, as I said, you can use the PCT. Our trial is testing the combination of the two. So you can't use other rapid PCR-based diagnostics coupled with the procalcitonin. That would be not suitable for the trial, but PCT on its own can be. And the bedside nurse or the doctors can collect those samples. That's not a problem either. Again, okay. So now let's move to the second part, the conservative fluid and deresuscitation. The aim of this is, if you get randomized into this conservative arm, the initial fluid resuscitation should, as I said, should have already been complete. And what we were saying is, from that point onward, if fluid boluses are needed, they may well be, but do that with these overt signs of hypovolemia. So that's sort of skin mottling beyond the area of the kneecap. And so that what we mean is there's a lot of mottling. And many people have asked questions about this, and we've actually now gone back to the original publications that describe this, and we've got pictures so we can show you that. But essentially is the mottling, if a patient is beyond their kneecap, it doesn't mean all the way from their foot to their knee. It's not that much mottling, but the sort of area of the kneecap. If they're mottling beyond that, then we're saying give fluid. If you can't maintain their blood pressure by just standard up titration of noradrenaline, it may go up and down a little bit. But if it's constantly rising and you feel therefore rather hypovolemic, of course you should give them a fluid bolus. And similarly, if their lactate is high, but we're saying above 3, so it doesn't just mean a little bit raised, but again, signs that they may be hypoperfused, that would be the indication. And on day 1, if they're markedly oliguric, so less than a quarter of a mil per kilo per hour on day 1. What we're saying that is often patients on day 2, 3 may be oliguric, in a diurnal pattern, and we're trying to avoid giving them fluid overnight, for instance, when the urine output drops. So this is that we're only using this criteria on day 1 to replace fluid. And what we're saying is give the bolus and reassess. If it's made some improvement, but not fully improved, give another bolus. But if you're doing that and then after you've given a litre and it's not making any difference at all, then maybe actually stop and maybe don't give any more fluid. The patient actually isn't hypovolemic and there may be other underlying issues. You carry on normal feeding, but there should be no maintenance fluid. As again, we're saying these patients will have had their fluid depletion corrected before they're included into the study. Feed them as and when you would normally. but don't run background fluid. Many of these patients are getting many liters of fluid through their drugs and the feeding and so on. So we're saying no maintenance fluid. Obviously, if they're bleeding or they're losing fluid through other losses through drains, you can replace that with correct hypovolemia. And then what we're saying then importantly from the second day onwards is assess if the patient is cardiovascularly stable. If they are stable, and we define that as being on noradrenaline less than 0.2 mics per kilo per minute, and it's not going up. And if they have signs of fluid overload, so more than 3 liters positive with edema in more than one place, then start taking the fluid off with deresuscitation. And it's a combination of indapamide, a frusemide bolus followed by infusion, and we're aiming for roughly a negative fluid balance of 1 liter a day. If they happen to be on renal replacement therapy, just remove the fluid through the filter. And assess daily over that period, day 2 to 5. And once they're no longer fluid overloaded, then you would stop the deresuscitation. And so there's an algorithm we provide you with. You probably can't see it, small text, so just breaking it down that says what to do on day 1 about not giving routine IV fluid, giving drugs in the smallest volume possible, and avoid giving boluses of fluid unless there are those objective criteria for hypovolemia. On day 2 to 5, again, top box there saying looking for signs of fluid overload, and if they're cardiovascularly stable. If they're not cardiovascularly stable, don't start taking the fluid off. So if their noradrenaline is at 0.3, we're saying wait, don't start taking the fluid off. But once they become cardiovascularly stable, lower doses of noradrenaline, then start taking the fluid off. And there are some troubleshooting guidelines of how to deal with any electrolyte disturbances. Standard of care, you can do what you like. Obviously, ideally, you should be following guidelines, which actually say Surviving Sepsis campaign says give fluid administration as long as the hemodynamic keep improving. You can use diuretics in this part of the trial if that's part of your standard of care. We've been asked this question a lot. Can I use frusemide in this arm? You can. What we want to avoid is you just replicating the treatment arm. And I would suggest many of us probably don't start resuscitation on day 2. My personal practice, I sometimes do try to take fluid off on very overloaded patients, but it's rarely at day 2. It's much later in their stay. And so again, we're asking sites to try and stick to their normal practice here. So yes, some of the frequently asked questions is saying, well, I already run a conservative fluid therapy. And I would suggest we perhaps as a community are more conservative in our fluid strategy than we have been in the past. But that's fine. If it doesn't really mimic what we're proposing in the intervention arm, that's okay. I would think it's unlikely many sites are doing what we're proposing. So that's okay. And then that point I mentioned already is, as we have multiple arms, do you have to take part in all aspects? We would like people to take part in all 3 arms, but if you can't for any reasons, and you've discussed things like the ADAPT sepsis and shorter trial, how that may work. You could be in components, but trials 1 and 2, the fluids and the diagnostic go together, and the GM-CSF bit is separate. So you can be in trials 1 and 2 together, or you can be in 3 alone, or all 3, but you can't pick and choose between 1 and 2, as they have to go hand in hand. The GM-CSF we're giving is if the patient is randomized to this arm, it's weight-based dosing. Most patients will be in the 50 to 125 kilograms, so it's got 500 micrograms subcutaneously, injection once a day for 8 days. So the GM-CSF comes as a powder that needs to be kept in the fridge, be reconstituted at the bedside, and you can keep once a patient is allocated their drug, you can keep the powder at the bedside for the 8 days. but once you reconstitute it, you need to give it pretty immediately afterwards. It can be done by the bedside nurse using sterile water. We've got guidance about how to do that. As I said, it's for 8 days. We expect many of these patients to be in the ICU for many days. If they are discharged before 8 days, we've said, if possible, continue it on the ward, because there's some evidence that if you stop it before 8 days, and maybe this is some of the evidence from previous trials, that maybe they gave it for too short a duration. So we're trying to give it for 8 days if we can. I realize giving IMP on the ward for an ICU-based trial is difficult. So it's not a protocol deviation if you don't, but we would ask you to try and do it. And it is double blind, and there is a matching placebo for that. This part of the trial is not open just yet because the labeling of the drug is now all in the country and is with the pharmacy that are doing the labeling for us to blind it. So that will open in the next week or two. And what you'll do, and maybe Janice, shall I bring you in here about ordering this?
Yep.
Again, probably don't need to go into too much detail, but just tell the sites roughly what will happen.
Yep. So at each site, we envisage you will have an unblinded pharmacist, and the unblinded pharmacist will have access to our database and will be able to see the unblinded list of placebo and IMP. We will provide all sites with 8 patient worth of drug initially. So you'll have 4 IMP and 4 placebo. Each box contains 16 vials, which is equal to 1 patient worth, depending on the weight. And the unblinded pharmacist will take delivery of the stock and will assign an equal number of IMP and placebo to the ICU and will replenish stock. So this is why they need the unblinded list, so they can ensure that the stock on ICU will always be balanced. And then once the site has around 4 kits left, we can send more stock.
Yep. And you could choose to put all 8 boxes in your ICU up front, but we just think many ICUs, we struggle for storage space, and therefore it's best to only put, say, 4 up in the ICU. That way you can always randomize patient at the weekend. If you're lucky and got 2 patients at the weekend, there would be enough IMP for those patients, and then you can restock it from your pharmacy the next week, and we can order you more. We can go into more details, but that's how it will work. And again, questions we've been asked already as we've been doing setups. Can the IMP be administered by a non-research nurse? Yes, as long as they're clinically trained to give the drugs at the bedside nurse can give it. That's absolutely fine. And as I've mentioned, if the patient is discharged before day 8, try to give it on the ward if at all possible. Won't worry about the schedules, but they're there. You can see them all. Our primary outcome is 90-day mortality and, as I said, clinical state. And what this means is we are looking at not just whether people live or die by day 90, but the patients, when we asked them what do they say was important to them, is they said, well, we want to improve our survival, but we also want to speed up our recovery. So it's a sort of composite endpoint that looks at the amount of time they spend in ICU on organ support, whether they're in hospital without organ support or they're discharged home. And we will collect that information, and it gives us more power. If these, particularly the diagnostic, we think could help speed time getting out of hospital, for instance. We haven't got, I was looking for the follow-up because we got the follow-ups.
Yeah, I think it's a few slides through.
So we do have the long-term follow-up. We are asking you guys to do that, and as well as the assessment of whether the patient is alive or dead or not. We are also doing some quality of life assessments and cognitive assessments. And so EQ5D 5L and the MOCA blind study, and we provide training for that for your sites to do that. And again, this has come from patients, so telling us that it's not just about mortality. We're trying to improve other aspects of their survival, the quality of their survival. I will just go back then to the study. Just as you saw the numbers right at the beginning, it's a large study, but we're hoping to open 60 centres. When you work that out with a 3-year recruitment, it's only 2 patients per ICU per month. So far, the sites at Imperial that we've got open, we've been doing about 1 patient a week, so 4 a month on each of the ICUs. We have multiple ICUs. So I think it is very doable to recruit. That's for the larger number, and obviously the GMCSF would be smaller numbers. We do have an internal pilot due at the end of this year, where we were supposed to have recruited 350 patients. We have 10 so far, having just started recruiting really in January. So we're doing okay for the number of sites open, but we do need more sites open. I won't go through details of consent now, but we've got clear guidance about how we do that, including using personal or professional legal representatives, and how to obtain the retrospective consent when the patient regains capacity, and when we can use telephone consent, and so on. I think the sample management, we're still trying to optimize. We've got guidance again, and David Ancliffe is leading on this, and has made very clear instructions about the different sampling we need for both PCR, and then it's got funding for the FLIP SepTiC study, which is trying to look at precision medicine in the fluid resuscitation. Now, there's patients who are hyperinflammatory respond differently to therapy, so it's important to collect some other samples. And we will provide you with all the kits for this. They get shipped out to you with labels to stick on. We've tried to make it as easy as possible. And the samples get shipped back to us at the moment in these Royal Mail safe boxes. We're finding postage is a challenge right now. And so we can go into some details with you around, I think really the key thing is to find out what is the most efficient way of getting the post back to us. And that includes, so much we're learning about the postage system, that these priority post boxes that we had in COVID are the ones now called late collection post boxes, and may have collections twice a day. And these seem to be the better options to use. In view of time, I will pause there and sort of give people a chance to ask any more questions. And while you're thinking about them, to turn to the team, Janice, just to explain what you want from sites and what we're going to provide in terms of further Q&A sessions, because obviously we could go on for hours, but I think it's wise to stick to an hour at a time. But we will have these frequently. We think this is the best way to engage with you. But what would you like sites to do as about getting set up and contacting you?
Yeah, so we are reaching out to all sites. If you've completed a feasibility form, that's the first step, and then we'll follow up with an evaluation where we'll discuss the study, and then we'll add you to our site selection list and send you the local information pack. There are quite a few sites now that are in that stage of reviewing that pack, and once we've received the documents, we'll arrange an SIV and then get you open. And as Tony says, at the moment we're opening diagnostic and fluid, and then GMCSF should be hopefully by the end of this month. But if you want to start the fluid and diagnostic to start with and add GMCSF once the study's embedded, you can do that too. But yeah, just reach out to us, any questions you've got. And as Tony mentioned, we do plan to continue with these Q&A webinar sessions each month. And do let us know if there's something, as Tony says, it's quite a lot to cover in an hour. So let us know if there's something in particular you want us to just focus on or discuss in more detail. We can arrange the webinars so that on one month we can focus on one part of the trial and so on. So do let us know.